So it's a great pleasure to be here today to talk about long-term complications in patients with HIV with regards to their kidney and protecting their kidney function. And I have some disclosures shown on this slide here. So why is this an important topic? Well, reduced kidney function is very common in the general population, and up to 10% of the general population in most countries have some degree of chronic kidney disease. Chronic kidney disease confers very significant risks for health and for death. It increases morbidity and mortality. It's common in patients living with HIV and getting commoner for reasons that I'll tell you about in a second. And various aspects of HIV itself and its treatment confer additional risks than the general population for chronic kidney disease. And most importantly, we can do something about it. We can prevent these risks accumulating and prevent harm to patients, and most of this very easily. Many of you will have seen this sort of slide before, and this just shows on the left-hand side the various stages of chronic kidney disease with the GFRs that they allude to and degrees of proteinuria or albuminuria along the top. And the shading is meant to tell us that as chronic kidney disease progresses to stage 3, 4, and 5, risks of all sorts increase, as they do with increasing proteinuria. So if you're in the bottom right-hand corner with lowest GFR and highest proteinuria, you have the highest risk for all sorts of outcomes, including cardiovascular disease. This is just data in patients without HIV in the UK, but the same all over the world. And what it shows you is that chronic kidney disease is not common in young people, but once you're over the age of 65, then up to 15% of the population have it. And by the time people are 75 or over, almost 40% of the population have chronic kidney disease. And you'll all recognize, therefore, that in HIV, this is going to be an issue as our population ages. And these, again, in non-HIV patients, are the risks that chronic kidney disease poses, with worsening GFR and worsening proteinuria in the top left, increasing risks of acute kidney injury with other events. In the bottom right, increasing risks of kidney failure. And in the middle, much more importantly, are the increasing risks of all cardiovascular outcomes, strokes and heart attacks, with worsening GFR and worsening proteinuria. So this is the data first presented in Japan for patients living with HIV. And this was just a study to look at the prevalence of chronic kidney disease. And of course, the Japanese population has very low risks overall of chronic kidney disease and cardiovascular outcomes. But what it showed us very nicely 5 years ago was that up to 14% of this cohort already had chronic kidney disease, none of them very severe, but with GFRs of less than 60 and with worsening proteinuria. And this is data from 5 years ago, and the situation is getting much more common and therefore, in essence, worse. And this, again, is lovely data showing that in the 10-year period from 2004 to 2014, the prevalence in patients living with HIV of chronic kidney disease, cardiovascular events, fractures, diabetes, hypertension, dyslipidemia has all increased really very dramatically. And we all know why. The population is aging, we're better at treating HIV, and the prevalence of chronic diseases is substantially increasing. This is very recent data from the DAD study, and this is the cohort of patients with GFRs of less than 60, so chronic kidney disease, showing really very dramatically increased risks for all sorts of outcomes. So this graph just shows you that at 5 years, for example, the risks of death of people living with HIV with known chronic kidney disease were over 10%, and that's substantially higher than people without chronic kidney disease. And if we then compare patients with and without chronic kidney disease, the next slide will show you these relatively increased risks. So again, this is the risk ratios, essentially, of people with chronic kidney disease and HIV and those without chronic kidney disease and HIV. And of course, there's a massively increased risk of end-stage renal disease, but much more surprising, increased risks, for example, of end-stage liver disease and even of the non-AIDS cancers, as well as cardiovascular disease. So chronic kidney disease is posing significant risks for our patients, with all sorts of outcomes unless we can do something about it. So there's lots of data now telling us what the risk factors are in people living with HIV. And some of them, of course, we can't change. So older age, undoubtedly, and Black ethnicity do increase the risks. An EGFR of less than 60 at baseline increases the risk, or if you move into that group at any point. But actually, the two biggest risks are hypertension and diabetes. And even if they're not going to be managed perfectly by an HIV team, at least HIV teams should be good at recognizing these, encouraging patients to take control and referring to the appropriate physicians. Ongoing viremia and previous hepatitis C are also well described as risk factors. And using this sort of information, we can therefore identify the people most at risk. ARV use does contribute to risk, but this is substantially less than the risk from, for example, diabetes and hypertension. And the data is pretty clear that boosted protease inhibitors, and especially lopinavir and atazanavir, increase the risk of chronic kidney disease. And tenofovir disoproxil fumarate increases the risk as well, but not as much as the others. But again, to put this in context, this risk is lower than the risks from diabetes, hypertension, and the other cardiovascular risks. This is summarized nicely on this review from a couple of years ago, and I encourage you to look at it if you're interested. But there are other factors we haven't got time to talk about, including host genetic factors such as carrying APOL1 gene variants, together with other risks, particularly socio-demographic ones. All of this information has led to the creation of risk scores for chronic kidney disease. The two best known are the Veterans Association and the DAD study risk scores, but essentially they use the information I've just shown you, the presence of low GFR to start with, increasing age, diabetes, hypertension, to give you a score for risk of progressive chronic kidney disease. And these can be useful for giving an outline, but I wouldn't take the numbers they generate to be in themselves facts. They just tell you patients at increased risk. So how can we monitor this? Well, in our services, in our HIV services, we can monitor kidney function by measuring the creatinine and then getting estimated GFRs. Measuring true GFRs is much less needed, but sometimes if we're not sure whether people truly do have chronic kidney damage. Measuring urine protein is critical, and an albumin creatinine ratio will tell us much more about glomerular health, whereas a protein creatinine ratio in general will also give us information about tubular damage, because some of that protein is tubular protein. And again, serum phosphates or phosphate leaks and measuring for glycosuria will also tell us whether there's tubular damage, and tubular damage in general is going to be from antiretroviral drugs, whereas glomerular damage from HIV itself and from hypertension and diabetes. So when should we be concerned? Well, I've already alluded to the various risk factors, and those are the issues we should think about. So patients with GFRs of less than 60 and certainly less than 75 if they're younger. Those with proteinuria at the outset, and especially albuminuria, that's much more predictive of progressive decline in kidney function. People with hypertension, diabetes, and pre-existing cardiovascular disease. Those with ongoing viremia. And then if they've got other risks, those with ARVs such as protease inhibitors. This is the one study I'll show you about changing antiretroviral drugs. And this was one of the earlier NICE studies showing that a switch from TDF, tenofovir disoproxil fumarate, to a TAF-based regime significantly reduced proteinuria. And on the far left, you can see that before the switch in pink to after the switch to TAF, the degree of total protein creatinine ratio, the proteinuria, halved and went to the baseline level of people not on TDF. So in people with risk factors for chronic kidney disease and with established chronic kidney disease, a switch away from protease inhibitors and TDF will be beneficial for their kidney health. And really, the last thing to say about this, small changes make a very big difference. This is just a graph. If you imagine a 25-year-old with a GFR of 100, losing 1 mil per minute per year of GFR from age 25, they will still have functioning kidneys when they die. But if they were to lose kidney function just at 2 mils per minute per year, By the time they're 70, they will need dialysis. So very small changes and improvements in kidney health and slowing down progression make a very dramatic difference to the long-term risks for people. And that's just for their kidney health, let alone cardiovascular risks. And reducing proteinuria does a similar thing. So what can you do? What can we do in our HIV teams? Well, we can encourage and support and activate patients so they understand that if they have a degree of kidney damage or they are at risk, they need to be engaged, monitor, and to change their lifestyles. We can measure the urine protein at the outset and the serum creatinine and EGFR and measure patients' blood pressure. So we can recognize and treat this early, and we can check this annually. We can treat the diabetes and the hypertension aggressively, and if that isn't going to be us, then make sure that patients are engaged with a service that will support them to do so. Blood pressure should be less than 130/80 if people have proteinuria. We should encourage them to exercise, eat a standard healthy diet. There's no specific kidney diet at early chronic kidney disease, and stop smoking, of course. If people have risk factors for progressive chronic kidney disease, we should carefully consider the antiretroviral drugs and use ones with no risk for the kidneys. And that sort of strategy can be summarized in this cartoon. We can identify the patients who are at low risk, they've got high GFRs, no proteinuria, and are younger, and those who are at higher risk, and therefore monitor appropriately, support and refer to ancillary services. I'm going to tell you a story to finish with. Here's Ahmed. He's 30 years old, and he's diagnosed with HIV at a sexual health check and treated with ATRIPLA. He's very good at taking his antiretroviral drugs, but he often fails to be reviewed in person. And the HIV clinic never checks his blood pressure. At the age of 40, he is noted by his GP to have higher blood pressure, but he doesn't return for a further check because he felt well. 4 years later, he has a chest infection, is treated with antibiotics, but actually this declines and he gets an episode of acute kidney injury from pneumonia, and he doesn't go for follow-up blood tests after discharge despite being asked to. And a further year later, at his kidney review, his HIV review, he's found to have a GFR of 27 and significant hypertension and diabetes. At this point, he's referred to other services, but essentially it's too late. And 5 years later, he's needing to be worked up for a transplant, but has established cardiovascular disease, and sadly, 3 years later, has a stroke and dies. So we could imagine Ahmed, though, with his optimal care, and it's not very complex. He's 30 years old, he's diagnosed with HIV at his sexual health check, but he's also found to have proteinuria at the outset. So his ARVs are changed straight away to a Kyvexa-based regime, and his GP is informed, and the GP supports him to stress the importance of ongoing care. Because he's got proteinuria from the outset, he has regular checks of his blood pressure, and his GP practice nurse monitors this assiduously with him. The HIV clinic is very good at also supporting this and checking his kidney function. Over the next 10 years, he does very well. He does lose kidney function, but much more slowly. And actually his ARVs are changed subsequently to Biktarvy. He gets a chest infection, but because everybody is aware of his risks of acute kidney injury, he is more closely monitored, and he does reach end-stage kidney disease, but in a planned fashion and much older, when he has the option of a living transplant from a friend, and at age 71, he's still doing extremely well. So there's lots that we can do to prevent the harms from chronic kidney disease. Encourage, support our patients, treat their vascular disease and their diabetes, treat their proteinuria, control their HIV viremia, and manage their risk factors. Thank you.